Hi, Kathleen. Thanks for joining me here today.
Hi, Walt. I couldn't be happier to be here with you.
Great. Take a moment and introduce yourself, if you will.
Sure. Hi, everybody. My name is Kathleen Benanti. I'm a manual therapist. I specialize in working with elite endurance athletes and also people with chronic pain conditions. I own Integrative Sports Therapies and Institute in Dallas, Texas, where I bring in advanced instructors from around the country to teach all of their wonderful skills to people in North Texas and beyond. And I'm an instructor for Eric Dalton. I
Great.
teach musculoskeletal alignment techniques.
Great. And full disclosure, I've held classes at your facility a couple times
Yes.
in the past, and we've got another one coming up next year. So full disclosure on that. But the purpose of these videos is to maybe allow a person who's interested in learning maybe a little different kind of work, sort of an overview of how my work differs, but also then maybe how the work that I taught was then rolled into existing interventions. A lot of the videos that we've done so far are with speech pathologists, but we have some, I think, with massage therapists, voice coach, et cetera, et cetera. And as a massage therapist, you've taken a couple classes from me. Granted, they've been, well, I guess it's been almost 8 years since I taught there, last 2017. So
Yeah.
when I return next year, it's going to be maybe a bit of a shift in terms of some of the things that I teach. Certainly the hands-on, but the narrative that comes with it. And I guess that's what I'm looking for. How do you see this work fitting in with the existing skills of a massage therapist, of a manual therapist?
Well, that's a great question. One of the things that immediately won me over was your commitment to evidence, the way you continually expand your catalog of research and frankly call out unsubstantiated claims.
Mhm.
It's so rare, and that's what immediately draw me to your work. Um, Pre-manual therapy, pre-massage, I have an academic background in research science. And so it was really a struggle for me when I entered massage therapy to find my people,
Mhm.
right? I don't want to hear you tell me your truths. I want some research and fact to back that up. And so I started playing with your work pretty early on after I took your voice, throat, and swallowing disorders workshop to see how I could integrate that with um, endurance athletes.
Mhm.
How could I for what is the relationship between the inside of the mouth and the anterior neck that I could turn into a system or a pathway for them to improve their athletic performance? And what I really found was some super interesting things, like the tongue. For instance, a retracted tongue can increase submental hyoid tension and it pulls the jaw forward and down a little bit. So I started working with my cyclists since they're already in a forward tilted position to try and release their tongue before they perform to see if it will make their upper respiratory breathing a little bit easier. And I found it to have a significant impact. I think I have a lot of cyclists out there pulling on their tongues before they ride and wondering what else is going on. Something about the gentle release and proprioceptive awareness that you can give people with this work um, can make a world of difference. It encourages kind of nasal flow and I just found it to be greatly successful with my endurance athletes.
Yeah, it's a really neat, fresh take on the use of tongue work. Because it's understood within a lot of the airway community, the myofunctional community, which we can talk about that at a different time. Views airway issues when it comes to tongue position, tongue posturing, resting, the whole thing. And the addition of some of that gentle stretch can often make an influence with those populations, but then translating that into your cyclist, cycle racer population. I think that's really an interesting piece because over the last couple of years, the realization of airway impacts has become a real strong point of the work that I teach, and I don't think it was much back in 2017. So kudos to you for kind of taking that on your own.
Well, all I need is something with some evidence-based or science-based
Mhm.
backing for me to tinker with and see how else I can apply this. I work with a unique population and their needs are very specific. And so that was the first thing that I did was advise them as to how to address some of their anterior neck um, tissues and manipulate the tongue. And then I started thinking about the uh, respiratory diaphragm to pelvic floor relationship and that pressure relationship, and that they're so interlinked that perhaps if I can provide work to address the upper airway, that then I can influence the pelvic diaphragm, which is essential to really all endurance athletes
Sure,
as
sure.
far as function goes. So I've been tinkering with it a good bit.
Yeah. I think that's been one of the things that has been my MO over the past couple of decades is really, trying to find evidence to support our work. And I think, without pointing any fingers, because I don't mean to do that right now, I think you and I have both been exposed to a lot of coursework where either there's a total abandonment of evidence. No, patient satisfaction is our evidence that we're looking for, which of course it is, but I think we can do better. But then what I see really common in not just the massage CE world, but PT, et cetera, is sort of a distortion of evidence to sort of fit the model that they're trying to sell you. And I, I'm rather vocal on social media. I try not to be too inflammatory, but I don't like shy away from that. But a lot of people believe the evidence that they were often taught in a continuing ed workshop is actually true and actually applies to what you're talking about. And I think those are really difficult things to sort of, unprise somebody's fingers from when you're exposing them to the bigger piece of the evidence-based world.
It can be very challenging. I just taught a workshop last weekend. I have a couple of little breakouts that I do. The subject matter isn't important to our conversation, but I leave these questions very open-ended with why.
Mhm.
And I just pause and look around the room for, so as opposed to somebody told you to, why? What is the science? Why are we doing this?
Yeah.
And those are the toughest conversations that I have in any workshop. And I intentionally do it to ruffle feathers
Yeah. Yeah.
because
It's
it's the
fun,
only
isn't
way
it?
I can get,
Yeah.
it's the only way I can get them to think outside of this predetermined way that they've been, kind of brought along.
Yeah.
And the why questions are great for me because I want to see the eyeballs. I want to encourage some discussion. Eventually, it does get there, but mostly the why never gets answered.
Right.
So I mean, honestly, since the moment that I met you, I was drawn to you as my great hero.
Okay.
What immediately won me over was your commitment to the evidence, the way you continually expand your catalog of research, call out unsubstantiated claims in our field. It's so rare and it's so needed.
Yeah.
Um,
And often so abrasive, right? And I mean that in a genuine way because it's viewed as almost hypoc or sort of challenging the existing gods within our communities. And we've got a lot of those gods, right?
we do.
Yeah, and to me, the at least at this point where we are in the evidence and science and progress and knowledge, we don't know why manual therapy is creating an impact. We can certainly go to our historical narratives, whatever that might be, what you were taught in school or on the job, right? but the multitude of possibilities as to why touch creates impact. It's really ambiguous. And I am incredibly comfortable wallowing in uncertainty, as I like to say, because it really is incredibly uncertain. But I think that really makes, like you said, ruffles some feathers, makes people really uncomfortable. So we lean back into the simpler stories that are inherited from the tribe, right? And all that stuff. And, are we really changing minds, Kathleen? Maybe just a wee bit.
I'll take any mind that I can get a hold of.
Yeah.
If it's just one, I'll take it and run with it, and I'll keep that person by my side forever.
Yeah.
Um, Honestly, so my approach is to my work resides in the biopsychosocial pain model.
Hmm.
And so I feel like, as with you, a gentler, kinder, more open approach helps me win that entire body because they're only coming with the bio. They're coming with, I hurt, something is dysfunctional, this part of my body is not playing well. Well, what about the other two? Right? What about the psychological? What about the social? And so when I teach, I say I only have one client, and that's the person on the table. I don't overlay anybody else's, you know, past dysfunction or trauma that I've seen on top of that person. I also don't bring any ego into that room because I need to make as much space as possible for that person to express themselves. And I let them talk and talk and talk and talk and talk until they're done. And I listen to every single word. Something that I find really that works for me well is I document their notes. The words that they use end up in my documentation word for word because I think of the biopsychosocial pain model and that there's no real pain center in the brain, right? Not a one that we can put our finger on per se. The first thing that the brain wants to do when it's out of pain is forget the pain,
Hmm.
right? We can recall smells from childhood. We can recall all kinds of feelings and sensations, but theoretically, you know that you were in pain, but can you really recall that sensation? Not so much. So when we're looking for progress with a client, with a patient, my neck was killing me. I wanted to cut my head off. I'll read back to them. They say I wasn't in pain at all. Oh no, because your words 2 weeks ago were, I am so tortured, I want to cut my head off. Really? Yes. So that's one of the ways that I use this pain model to chart my progress with them. It has only a small bit of what I do, I feel like, is actually addressing the biological aspect of creating a place for them to heal. I am not a healer. There's no magic here. I don't really like that term.
Me neither.
Um, but I am providing a space for that entire body to come together.
Yeah. What about the conflict, though, between some of the work that you have learned and I've learned, where you really are, it's all about the mastery of a technique, right? And then, that sort of conflicts completely with that sense of, a lot of this is affective versus the physical, biologic aspect to it. And, I think that's really hard for people to wrestle because they're really paying money, the sunk cost of being an expert. And then someone like me or you comes along and says, well, maybe it's more about the relationship you're building with your client, right? That's Dem's fighting words, as people like to say, right?
I think so, and I love that. I love to stir that particular pot,
Yeah.
hoping that one or two people will float to the surface and I can scoop them out. Yeah, so I mean, I teach Eric Dalton's work, which is definitely technique heavy,
Mhm.
but it's also science heavy, and that's the reason why I kept coming back to his workshops year after year after year. There was never complacency with him, and there was never learn these techniques and just do them without there being a reason or a platform to jump in the first place. And luckily, Eric gives his few instructors, well, gave, still hard to believe that he's not here, but um, he gave us a lot of freedom to teach the class that we want to teach, as long as we are also putting forth the manual aspect. And so I spent a lot of time talking with them of breaking down kind of myths, asking hard questions, and a line that I use with my students and even with my clients is I don't rub and hope,
Mm.
right? Why am I touching anything until I have an idea, outside of diagnostics, until I have an idea of what my game plan is, what might actually be going on there, and where is it coming from in the body, not just where does it live now. So I teach don't rub and hope.
Yeah.
Um, Most of my clinical work in my office I wouldn't say most, but a lot of it is conversation. A
Mhm.
lot of it is conversation. Eventually, you'll peel enough of those layers off of them for them to give you truths that they didn't even know that they had about their own injuries.
Yeah.
So really, for me, the success in clinical work is providing as much space as you can
Yeah.
for that
Yeah.
person,
Yeah.
moving in slowly and pain-free.
Yeah. Since 2017, my phrasing and outlook of how I approach my own work here in my clinic, but also how I teach has changed pretty dramatically. I use the concept now that I wasn't using the words back then of shared decision making, right? Where I bring into the room a lot of knowledge, experience, um, but it ends where their experience and knowledge begins, right?
Yeah.
And I just think that that's become one of the more salient points of the conversation that I have with a client that, yep, I am an expert, but so are you, and I need that input from you. You might want to hand off our responsibility to me. No, I trust you. Do what you think is best for me. And I'll do that if necessary, but that feels so old to me that I think I know what I'd like to do with you, but how does this feel to you? Does it feel useful and helpful? Does it feel like it might be harmful? I love bringing that piece into it. And that's another one that, the expert manual therapist struggles with because it's all about, no, I know secret things that you don't because you didn't take fill in the blank of the name of the modality, right? And those are more hurdles we have to jump, not as much with the patients because the patients are on board with it. It's the therapists who, you know, are like, why would I ask my patient this? They know nothing about fascia, for instance. Yeah, but they know their body. And I think that's the missing link. I don't want to get too, kind of whatever cliche with it, but I think it really is a missing link in a lot of massage education, physical therapy education, manual therapy education, is the role of the other expert in the room.
Well, I'd like to think, I'd like to say that across the board with patients, clients, regardless of the particular aspect of healthcare in this country, they are trained to not advocate for themselves.
Mhm.
And they're trained to keep quiet
Mhm.
and respect the advice of people who know better.
Yeah.
And I find that that's one of the bigger challenges in me working with clients is to help them understand that, in fact, they have full ownership of this body and they are allowed to feel pain where they feel pain as opposed to discount it. That it's not that bad. Maybe it doesn't exist. Maybe it's all in my head. That is the protective ice that I'm trying to break through with them. Once I can do that, I feel like I can win them. I provide a safe zone for them to allow it all to come out. And then surprisingly, they start to feel pain in certain areas and recognize it as opposed to just being trained to dismiss and bow to authority.
Yeah.
It's
And I also think that, that whole, well, if we can call it that pain science movement of about, not quite a decade ago, it was misinterpreted by so many clinicians and then simplified and misinterpreted by so many patients of, oh, you mean I don't ha there's nothing wrong here, it's all in my head. And I think that was just from really awkward trying to explain it on our part to patients, and it got totally misrepresented. And a lot of people really took offense to that, therapists and patients.
well, I know that I'm different because I come from an academic background.
Hmm.
I get that. So I come to the plate with a lot of questions and very few answers. And I'm happy in that place because I'm trained to be that person. So I really understand therapists who come from any other kind of background. It's easy to believe what people of authority have told you, just like it's easy for the patient or client to believe what people of authority have told you and not question it. I try my best when I teach to hammer that in, whether it's me or anybody else. Question what they're saying, question the research, go look it up for yourself.
Yeah.
Is it peer reviewed? Is it peer reviewed in a journal that doesn't accept money?
Yeah.
I mean, there are lots of questions out there that are easy to find, but I think that that's just for me. I kind of came to this game with one big question mark and not a whole lot of answers, and I stay there. I like that.
Yeah. I think it's hard too for the average clinician to really keep up with the research, with the evidence. We're bombarded with a lot. To
A
me,
lot.
like Google Scholar alerts is a lifesaver for me because every day I get an email from Google saying, "Hey, here's some new papers that have come out that match your search query." And just last week, I was fed a paper from Google Scholar or somewhere. I don't remember where it came from. It doesn't really matter. But it was a paper that really sort of caused me to pause and say, hey, these are pearls for teaching. It was a paper where they looked at the application of stretching to the face because of the certain characteristics of the face with a load of cutaneous receptors in the lip region, that stretching the skin of the lip before an activity actually was able to demonstrably improve motor planning of that facial region. So
Really?
take a look at that for a second. Stretch somebody's face, and we explained the reason why it helps with articulation, with pain, with movement, based on those tissue stories that we were taught. Oh, there's scar tissue, it was fascia restriction, it was weakness, all that stuff. And it's certainly, I don't want to negate that. It can be. But then I
Sure.
see a paper like that, which really makes my head go, hey, wait a minute, right? That's a whole different perspective on how something as simple as doing that could map up in the brain the ability to better motor plan movement. And I mean, those are the kind of pearls that I think we should be celebrating on social media, and instead of the constant piling on of, oh, I don't know, of all the different tissue stories that you and I have been exposed to, not that they don't matter, but they're really incomplete.
True.
But is there a but coming in?
No, there's not a but coming. What I would love to get away from the tissue conversation
Mhm.
because I really just don't find much action in the tissues
Yeah,
directly.
yeah,
It's I feel like we're very often hammering away at the thing that is the result of the problem, not the cause of the problem.
absolutely,
And
absolutely.
I'd rather spend a whole lot less time, if no time, doing that.
Yeah,
Um, yeah, I know that it's not easy for a lot of people.
yeah, yeah,
Um, but I mean, I found myself drawing parallels to the kind of subtle, precise touch I use with chronic pain clients and athletes. And what stood out to me most was your emphasis on restraint, right? So that's again going back to the tissues of if we are managing tissue, how are we managing it? Am I now a threat to the nervous system,
yeah,
right?
yeah,
Am I putting the nervous system into a compromised position? And then there's little to no chance of that person getting real clinical help from me. It the influence doesn't always involve pressure.
yeah,
That really resonates with me. Um,
yeah,
it's how I treat, it's how I teach, and it definitely expands how I think about things like the anterior neck and
yeah,
the role in breath and posture.
yeah. There's a paper that came out since I saw you last in 2017, and it's certainly more applicable within the speech pathology community, but yet I think it's broadly applicable when you take a look at what they did. They did a study where they had a woman with what's called muscle tension dysphonia, and it's basically
Yeah,
hoarseness. And with that sort of pattern, they already know that it sets up a dysregulated brain activity when it comes to formation of the words. That they literally can take an MRI of somebody's brain while they're speaking and see the dysregulation. But what they did, now get this study. They slid a woman in an MRI and they had her read a script. She had muscle tension dysphonia. They they had her read the script and they recorded the dysregulated brain activity. Then they pulled her out of the MRI. They performed the equivalent of a session of laryngeal manipulation, reposturing, et cetera, et cetera. And they got her voice down to a more normal level. And then, 20 minutes later, they slid her back in the MRI and they had her read the same script. And what they saw was an entirely different level of brain activity. And that study doesn't show the problem's not here, it's here.
right.
But the study definitely points to it is a central nervous system issue, both maybe the cause and the effect. And, can everybody have access to an MRI to do those sorts of pre and post studies when it comes to manual therapy? Possibly not, but I think that's a maturity when we look at studies being done like that versus using it as a reason to validate the historical claims we've made. And I think that's a big mistake in most manual therapy studies is, they lay out a narrative, that the person has a fascia restriction. And here's somebody who said something about a past paper. And then we go to do fascia work on them and they improve and they feel like they validated that historical story, which is definitely that post hoc fallacy. But to me, this is why research can be so important to even the boots on the ground clinician to see that, well, okay, I thought it was this, but maybe it's more nuanced. Maybe it's more complex than that. And that's the message that I try and translate. It's not your fascia stupid, but even if it is your fascia, is the fascia acting or the muscle knot or whatever, is it acting independently out there in the periphery all by
Right.
itself without some sort of a central origin? And I think that's what's missing from these conversations.
Shy of acute injury, right? If I whack myself here, I'm injured there.
Mhm.
Everything else is relationships. And that's what I'm always looking for. What are the relationships here? I don't find really anything outside of acute injury that I can think of where this is the problem, this is the cause, and I can address it right here, all in the same place.
Right.
Some muscles do respond like that.
Yeah.
But again, there's always a relationship. Pterygoids,
Yeah.
that is one of the great instant releases that I feel good that can live on its own.
Hmm.
And a few other regions like pelvic floor can have a really quick, amazing instant release and relief. But again, there's a bigger issue there.
There
So
is. And is it the pterygoid in and of itself that
no,
decided to have a bad day, week, month, year with life? Or are there other factors? And sure, we could go into the posture piece because that's a common one. We could go to the jaw alignment piece. We could go to patterns, all those things. And to simplify it, to say it's your pterygoid, I think is just doing an incredible disservice to the complexities of who this person in front of us really is.
I agree. I with certain tissue works, and I'll go back to the pterygoids. That's one thing that I um, learned how to master from you, and immediately started teaching it to every single person that was willing to listen on my table, especially my athletes, because for them, I'm after performance enhancement. At that point, how their body feels means nothing to me. Are they going to podium or are they not going to podium? Those are my people. So those are the folks that I do appreciate short-term releases for.
Yeah.
Will it make them faster with improved performance, with their body feeling better and less pain, with faster performance times? So for them, those are the shotgun techniques that I have them doing out there of work your pterygoids, pull your tongue,
Yeah.
let's get this head and neck situated before you go. We'll worry about dysfunction later. That's not our purpose right now.
Yeah.
So there are a lot of different ways that we can come after manual therapy, come towards manual therapy. You know what I mean?
Yeah, yeah, I do. Yeah. Well, I'm looking forward to coming back to Dallas next April, and
Me
well,
too.
to revisit with you, but also to present the work again. And I'm looking forward to that trip and looking forward to kind of sharing these ideas with you because I love meeting people out there who kind of share that sense that yeah, our work matters, but we need to know why and how in a deeper way.
Right.
And it's refreshing to hear that you're out that's you too.
I'm telling you, you are one of my great, great heroes, Walt Fritz.
Thank you. Thank you.
It's true.
Got it. So remote fist bump. There we go. Okay, boom.
Ooh.
All right. So anything else you want to share with the audience here of people? Because basically they're looking, okay, what's this work all about? I mean, I think you did a great job, but if there's anything else you want to share, feel free. Put you on the spot there. How's that?
You didn't put me on the spot, but I have to say that this would be more for the manual massage therapists. There is a great fun story about your intraoral workshop that a bunch of us still tell amongst one another.
Uh-oh.
And it pops up randomly and it's awesome. Um, and also for the SLPs listening, fear not touching people.
Hmm.
In this workshop, it was pretty packed. It was almost 30 people, mostly SLPs, the one that I hosted and took. But there were a bunch of massage therapists in there as well. So the massage therapists, we're all getting ready to let's get in there. Let's stick our fingers in there and play around, not realizing that not another SLP in the class had ever touched a person before.
Mhm.
We didn't realize that that was a possibility. And so we remember the fear on their faces of, I have to touch? How do you do it? These brilliant people, mostly PhDs, and here are a lowly massage therapist saying, open your mouth, let me get in there. But you took a moment to tell the SLPs in class, now when your hands get tired, after about 30 seconds, you can turn and take a few notes on your patient. And we still roll about that to this day of 30 seconds.
Yeah, yeah.
It was such a unique experience to bring manual therapists and SLPs together in one space to learn the same thing. I took so much from them in conversation regarding their work and how they can perform their work without touch,
Mhm.
which was fascinating to me. And in turn, they learned a lot from us about finding your comfortability
Yeah,
in touching somebody and that it's not as intimidating or scary as it may seem.
yeah.
But yeah, we still joke about the 30 seconds and rest thing to this day.
The one thing too, it just brought up another conversation too, because as you, so aptly put, speech pathologists have very, very little, if any, prior training in touch-based intervention, which is a very daunting thing, even without other people in the room like you who have a lot of experience. Like people come in with a sense of inferiority, like, I don't really know whether I'll be a good palpator, which is an understandable concern.
Sure.
But when you roll in shared decision making, you roll in the role of the patient actually can help you decide what you're palpating, if what you're palpating is relevant, if it's necessary to even worry about that. And I think that's been a really helpful thing for me to realize that for the newbie, this is intimidating, but if you incorporate patient feedback, it makes it so much easier.
Yeah.
Unfortunately, I think PTs, massage therapists, etc., we're on the opposite end. It's like, no, you could tell me that, but you don't know what I know. There's almost a no, yeah, pat their hand and say, yeah, that's nice, but you don't really know what's going on. And I think that's something that needs to be modified too. They do know what's going on, at least inside from a felt sense.
I agree with you. And I think that that's the reason why their body sometimes guides us anyway. I like to call it lizard brain activity, right? Our unconscious system.
The reptilian, yeah.
Yeah. Well, all of my clients know what lizard brain means. They've all heard it relentlessly. But when you're working with somebody, pick an area, pick a body part, even if it's unique, like pterygoids or anterior neck. Their body will respond to you and let you know that you're in the right place and you're doing the right thing subconsciously. We all hear it. Oh, or oh yeah, that's it. How do they know that? Oh yeah, that's it. Their conscious brain doesn't know. Oh yeah, that's it.
Yeah,
But they're just letting you know you are now addressing something that has been problematic to my system, and my system is telling you, oh yeah, that's part of the puzzle.
yeah.
So I think that their body tells us all the time if we're open to it. If we're busy listening to them, the body will tell us a lot of what we need to know. If we're busy listening to us, then our ego is taking up too much space in that room and there's not enough space for that person to fully emote.
Exactly.
That's
I
it.
think that we get in the way because we get so entrenched in being an intuitive and all those things that are taught to us that you stop listening to other people. And I think that's a shame.
Is it intuitive, or is it that we have a lot of knowledge that's back there and our lizard brains pull things out because our body already knows how to perform those actions and we know how to fill those gaps.
We are so on board because I view intuition not as a hit from heaven, but everything I've learned and witnessed up to this point in time, right? And
Yeah,
unfortunately, it gets sort of morphed into this supernatural thing that a lot of people really like to wear, right? And I get that,
sure.
right? Ego
I
is, we love our ego, stroke, but I just think that it doesn't always, it's not the place for it when we're trying to help another individual. That's my opinion.
My answer always is I am no more special than anybody else. The only reason why I know so much is because I've worked so hard to gain that knowledge. And that helps me manage this self-ego thing, which honestly, I think have whittled down to single digits now because I find that it just gets in the way.
Hmm.
And if I have a client that says, I say, no, no, it's the work. I study the work relentlessly. I know the work now, and now I'm able to give it back to you. So it's not me. I'm just the vehicle between the work and you and
Yeah,
providing a whole lot of space for that to happen.
yeah,
It just gets in the way.
yeah.
I try and separate myself from folks.
It's hard. Yeah.
I'll leave that as an open-ended
There
sentence.
you go. There you go. All right. Well, thanks for spending this time with me. I really appreciate you taking the time to share your
Well,
experiences, and I'm looking forward to, catching up again early next year in Dallas.
it will be great. And now when you want to get rid of people like me, you just say, exit stage right.
Yeah. There you go. Thanks, Kathleen.
Thanks, Walt.
All right.
Appreciate you. We'll see you soon, hun.
Okay. Bye.
Bye.